Dr. Raghu, in your practice in ADHF, what is your choice of the intravenous diuretic? Whether it is torsemide, furosemide, you have any choices specific, or is it okay that you can use both? Just your
No,
comment on that.
my practice is been using intravenous torsemide as a bolus followed by an infusion in my daily practice, and that has been there for close to a decade now. And the tips what I use to implement, I implement in the when I use the diuretic is I always use a natriuresis guided approach. That means once I start the patient on IV torsemide, I get a urinary spot sodium at the end of 2 hours. And if the urinary spot sodium is around 80, 60 to 80 is the target what I would like to achieve. And if I'm able to achieve it, I will continue the same dose. If I'm not achieving, it's around 40 or 35, or in that range, I will double the dose of the furosemide. So I have an objective basis for the up titration of the dose of the parenteral diuretic. That's what I use.
Thank you. Dr. Kumar, just one question on a diuretic issue. It's a diuretic issue. In your OPD, in your chronic, when you are actually looking at eplerenone versus spironolactone, Dr. Kumar, what is there the choice between the two, or what is your choice, or you think both are the same? When you are using these drugs, whether it's eplerenone or spironolactone, Dr. Kumar?
Yeah, so I really don't distinguish too much between the two. Of course, there are subtle differences. I know that, but of course, if the patient has any contraindications or side effects from spironolactone, definitely move to eplerenone. And of course, having said that, now we have a non-steroidal MRA also, which is now going to come into focus with the new data coming in from the fine arts study. And so we have finerenone also in patients with diabetes, CKD, and possibly patients who with preserved management of preserved ejection fraction heart failure.
Okay, thank you. Dr. Poddar, just one last question. What is your idea of complete nephron blockage? Now, how many patients you look at the whole loop, whether the complete nephron blockage, how many patients do you think you have to use this particular concept? Dr. Poddar?
It all depends on the renal function of the patient. I take into account the creatinine, the eGFR, and then I decide on that, sir.
Okay, fine, fair enough. So you look at the hemodynamic status and the metabolic parameters of the patient, and then decide whether he requires 1, 2, 3, or 4 diuretics. Okay. Now we move on to the main talk of today. That is ARNI. Now, Dr. Raghu, in your practice, first I want all three of you to answer. 4 pillars, optimal dosages. What is your percentage of patients achieving? Just quick, all 4 of you. You can start with, yes, Raghu.
I think 40%.
40%.
Of course, if you were looking at ARNI, 200 milligrams twice a day is not very frequent, but I have a large number of patients on 100 milligrams twice a day. And of course, we have one small set of patients who really do not tolerate things. And then we, of course, start them on a very low dose on 25 twice a day and try to up titrate. But 200 milligrams twice a day of ARNI, because the others don't require too much of a dose up titration. So I think we hear the molecule in focus is the ARNI, and I would say about 25 to 30% patients are on 200 milligrams twice a day.
Absolutely. Dr. Poddar?
Yes, sir. I try to use the 4 foundational therapies in all my patients by starting with a very low dose, because I find that and the literature also tells that low doses of foundational agents reduce morbidity and mortality, and the foundational therapies have benefits, provide benefits of each drug class for heart failure with reduced ejection fraction, and these benefits are independent of each other. So we can start with the 4 foundational therapies with very low dose, and then we can titrate.
Okay. Now, just quick again, coming to the same, only specifically ARNI, Dr. Raghu, 50 BD, 100 BD, average dose, and how many of the patients are below 50 or say 50 half BD? Just quick, I mean, we know it depends on hemodynamics and so many other factors, but just to know that what is your, Dr. Raghu, 50 BD, 100 BD?
0 less than 50. About, if you take a chronic heart failure patient, almost 80% of them are on 100 BD. Quite a few of them are 200, 100. And about a percentage, about 10 to 15% of them are on 200 BD.
Dr. Kumar,
But
what
none
about
less than 50.
AHF? Do you start with 50 half BD in at least, those really sick patients, Dr. Raghu? Dr. Kumar?
No, not exactly. I mean, see, as once the patient is coming out of an ICU setting, or basically, patient is, has a reducing dose of diuretics, patient is relatively isovolemic, and we have no contraindications on the potassium levels, and the blood pressure is well maintained. I mean, the minimum dose one would start is 50 milligrams twice a day. We have a certain number of patients who do not have any contraindications and who were on antihypertensives. There one would start with 100 milligrams twice a day.
Okay, fine. Dr. Poddar, quick comment.
So most patients of mine have with heart failure have low blood pressure. So many patients I initiate with 25 milligram twice daily, that is 50 half twice daily. Then I try to up-titrate.
Okay, fine. Okay, next parameter of ARNI is CKD and ARNI. Now, what is we all know EGFR and EGFR less than 30. So, your parameters for CKD. Now, suppose you start a patient with 30, Dr. Raghu, do you look at the creatinine level? This is because there are a lot of physicians who have joined. Many people, we don't know, we know it's EGFR. What is the parameter you are going to look at? Are you going to look at creatinine, only EGFR? And what is the rise where you would stop ARNI in a CKD patient? Dr. Raghu will have a quick comment on all. These are important practical points.
Yeah. I think less than 30 EGFR, I do not initiate an ARNI. That is the number one parameter what I see. So, for example, if the GFR is less than 30, I still continue 50 BD, but I will not start to initiate a patient. That's number one. Number two is what is the if the GFR or the serum creatinine, I think GFR becomes a very tough parameter. It's not a right parameter for me to monitor it. So whenever I initiate and look for the renal parameter worsening, I look at the creatinine. If it is more than 100%, I stop. 100%, that is double the number of the resting, I stop it. If it is 50% rise, then I would prefer to up titrate this one. 50 to 100, I take a one by one, case by case approach.
I think very important is important. Dr. Kumar, quick comments on this because this is a very important issue. People are paranoid about serum creatinine, CKD, and ARNI. So, we must tell them that initial rise, you have to be careful, but you should not stop because, if you improve the hemodynamics, eventually it will improve. So, Dr. Kumar, quick comments on CKD and ARNI.
It is expected to have a, kind of initial rise. I think up to a 25% initial rise one would accept. But if there's a rapid rise or, your potassium levels again are very important, do not permit it, then one would go cautiously. If the patient has a EGFR of less than 30, I do not normally start with this thing, with an ARNI. I probably would go for a hydralazine instead, and then just see how the hemodynamics behave, how the creatinine behaves, and then ease on to an ARNI.
Okay, Dr. Poddar, quick comment.
Yes, sir. I find that creatinine 2.5 and a potassium level of more than 5.5, I do not, I'm hesitant in introducing an ARNI. Let the creatinine come down and the potassium come down, then I'll introduce ARNI. That's my philosophy, sir.
Correct. So you should be careful about EGFR, serum creatinine when you look at the rise, and of course potassium more than 5.5. Important clinical tips. Okay, now again coming back to ARNI and EF. Dr. Raghu, initially, we used to look at EF and we used to be amazed. Now, remodeling parameters, we all know there's a lot of theory and a lot of papers of remodeling and ARNI. Really, do you really look at these remodeling parameters or you look at the EF? And how do you go about looking at the EF, or you are really into the different parameters mentioned in all the papers?
I
Practical.
think practical, yes. My predominant parameter would be ejection fraction less than 40, start on ARNI. Between 40 to 50, maybe ARNI based upon the patient's BNP and congestion state. Above 50, I'm very cautious. For HFpEF, I'm very cautious unless the patient has got lot of congested symptoms to start the patient on an ARNI.
Okay. Dr. Kumar, just your quick comment on which subset of patients you would think of starting ARNI in a heart failure with preserved EF. Dr. Kumar.
Well, I normally, practically going by the fact that, I would look at some parameters of diastolic dysfunction, and especially the patient has a raised LVDP on the echo. I take that as a significant reason to start an ARNI. And then I would also like to, in these patients, do an NT-proBNP.
Okay. And Dr. Poddar, again, your comment on EF. Do you look regularly at the EF at what time, and what is your experience of EF and ARNI?
Yes, sir, I check the EF, but not only EF, in the back of my mind, in all our mind, we should understand that ARNI improves the prognostically, it improves the heart failure, and it prevents sudden cardiac death.
Okay.
So,
Now coming to Dr. Dorai Raj or Manoj, see, you have so many patients, you do CABGs on patients with LV systolic dysfunction, 30, 35, high risk patients. So what is your approach to these patients? What time would you think of initiating ARNI post-discharge? Manoj, please.
Yeah, so I think that's a very important question because if a patient is stable preoperatively, I would prefer to start ARNI, in fact, preoperatively also, as soon as possible if I get a window of opportunity. How long before the surgery? I think if the patient allows me, maybe even a couple of weeks, 3 weeks, 4 weeks, whatever, because if the patient is congested and overloaded, obviously we need to treat the congestion first and make the patient stable before he goes for surgery rather than have a hot CABG on the table with a lot of supports and IABP. So I have started treating them acutely and then managing them for maybe even 10 to 15 days or maybe 3 weeks with GDMT. And we've been seeing that I can manage these patients off pump and without an IABP if they are optimally stabilized prior to surgery. Stopping ARNI is very important because there's a vasoplegic effect during the perioperative period. So at least 2 days before, because the washout has to be there. It holds the same with SGLT2 inhibitors, the same concept as valsartan, telmisartan, or any of the ARBs. We should stop them a couple of days before so that there's no vasoplegia because that's very difficult to treat. The only thing which works during surgery is vasopressin. Post-operatively, once the patient is, I wouldn't start ARNI in the recovery room, but once the patient is off supports, I would definitely start them on an SGLT2 inhibitor. And prior to discharge, if the renal parameters, hemodynamics are good, then definitely I would ensure that the patients are on GDMT how much ever possible before they go home. So that is what my criteria is, and that will carry on because the long-term legacy of patient on guideline-directed medical therapy is much, much better. I would not stop the ARNI for these patients because, as I think Dr. Poddar also mentioned, chances of sudden cardiac death are very high. Chances of repeat heart failure hospitalizations are very high for these patients, whether it's PTCA or CABG. So we have to have them on GDMT, sir.
Okay, thank you. That's what the important thing. That means even post-surgery, in fact, that's an important, RNA has an important, or GDMP, I would say, has very important contribution, which we should not neglect. Because what happens when surgery is done, patient is okay. In fact, we think that everything is okay, and that should be actually emphasized to the patient that no, they have to be on adequate GDMT even after the surgery is done, especially in all those patients who have an EF between 30 and 35 or less. Thank you. Now, one quick question, Dr. Kumar. Have you seen that, your incidence of ICD implants, transplants has gone down after GDMT and especially ARNI and GDMT, of course, the optimal dose because of improvement in LV function? So what do you think is your comment on that?
I don't think I have enough data to support that, but yes, anecdotally, we have seen patients who have improved EFs, and we have not had a need to put in a device because the EFs did improve. One has to be a little careful on this, interpretation. I think without going into extensive diagnostics, is that did the patient have any inflammation, or was the patient, had some ischemia? Then again, post revascularization, have you waited enough for the EF to come up? So we have a lot of confounding factors in this, just the EF itself for implanting a device.
Dr. Raghu, quick comment on this?
I think we had made tremendous progress with the implementation of GDMT. We have data. So the mortality of 50% mortality in 5 years is now 85% to 90% survival. That itself obviously leads to reduced patients being referred for cardiac transplantation or MCS and all that. So we have made a lot of progress with the GDMT.
No. Dr. Manoj, coming back to you. See, a lot of rheumatic heart disease patients, chronic AFibs have low EFs. So when you're operating these patients, even is that subset also important for you to start GDMT and ARNI, and what do you do with that subset of patients?
I think
Rheumatic heart disease.
I think that's a fantastic question, sir, because we have a huge subset of patients with valvular regurgitant lesions, actually, not the stenotic lesions. Stenotic lesions will definitely improve, but you have severe MRs with, there's an output mismatch on the echo. And these patients, you start them pre-operatively, the LV ejection fraction is 60%, but I go by DP by DT. If I find the DP by DT is around 600 or 500, 400, LV is struggling, you start them on GDMT for a month. Frankly speaking, if you find that the DP by DT is improving to 1000, 1200, you know that the patient is really going to rock off the table. I mean, do very well. And that will hold on, maybe because of reverse remodeling. I don't know. Maybe because of the LV picking up. I really don't know. Rheumatic population. But these patients do very well. So I think that's a beautiful subset which you're discussing. Rheumatic heart disease, severe MR, severe AR patients coming for surgery. GDMT definitely helps in optimizing them prior to surgery and keeping them, in fact, symptomatically better, sir, even post-surgery, sir.
Yeah, and again, I'm asking you the same question because, see, you are a transplant surgeon. You have done so many cardiac transplants now, and you have been doing it routinely. So, have you seen this, at least I would say, postponement of the transplants or maybe off the list because of GDMT? Because so many people are referred to you. So, what is your take on that?
I've had 5 patients, I mean, in my list who have come off the list, sir. I mean, come off the list means they have actually, there was one patient who came for transplant. There was an HLA positive match on the table, and that patient went off the list. And for some reason, that patient was on GDMT. Now it's 2 years. His LV is actually improved to 45%. He is able to walk. He's able to climb 4 stairs and 4 flights of stairs. And it's actually on the transplant, but came off on the table. So definitely it improves. I mean, I'm a transplant surgeon. I won't say anything worse than that. But even the patients whose LV doesn't improve, the actual quality of life also improves. It also helps us on maintaining a patient on the waiting list, survival till they get a transplant. That's also very important, sir. Keeping the patient till they get a donor is also important. So these 2 category of patients is what I'm looking at, sir. One is they have gone off the list. I agree, a small subset. But the guys who actually have to come for transplant, it makes them survive till the time of transplant.
Can I
Okay, now, yes, yes.
So, I mean, in this regard, we've had some patients, again, anecdotal reports where patients have improved dramatically, if not the EF, then the symptomatic status. I mean, we had this patient just recently when this patient was, came in from abroad and was doing very poorly, and we started the patient on ARNI. And day 3, the patient comes back, you see, I really need something. I'm okay. And similarly, we've had patients who did not tolerate ACE inhibitors even in small doses. So those, when we shifted back to ARNI, of course, we had to start with small doses, are tolerating ARNI almost up to 100 milligrams twice a day. So this is another thing I've noticed with, ACE inhibitors versus ARNI.
Yeah, thank you. Now, again, just one quick interesting question I want Dr. Raghu. See, sometimes you find young people, we label them as DCM, mostly they have viral myocarditis. And sometimes we find that their EF dramatically improves, It is 25-30%, it becomes back to normal. Now, such patients, what happens to your GDMT? We all know that GDMT should not be sort of reduced. But these people who come back to normal within a month or two, we find them. What do you do, Dr. Raghu?
It's a tough question, Dr. Sunil. But I used to stop 5-7 years ago, and I had bad experiences with those patients. So I realized that it is better to continue the medication. And sometimes nowadays I get a cardiac MRI done. If the structural changes are not there, sometimes I get into the mind that possibly can we stop the or reduce the GDMT. But honestly, I could not stop them because I'm very apprehensive to stop these medications or reduce the doses.
Dr. Kumar, your comments on reducing doses of any GDMT and what you do, you would like to keep the same despite the EF. What is your take on that?
Present day practice, I try to continue GDMT, except for, of course, diuretics are not a part of the GMT, so they're off diuretics. And I'm not sure about the MRA in these patients, but at least the 3 beta blocker, ARNI, and an SGLT2 inhibitors, I do always continue if there are no contraindications.
Thank you. Dr. Poddar, just one question on diuretics.
Sir?
Yes.
Sir, can I comment on
Yes,
this young
yes, yes.
patient?
Yeah,
Some
yeah.
of the patients, I mean, other than cardiac MRI, we've done PET scans for sarcoidosis also, because those are obviously, and they dramatically improve with steroids also. So, I mean, that is a subset of patients which is reversible, sir. And some of them have
Absolutely.
ended getting this CRTs and all at a very young age, and pacemakers. Most of them have syncopal attacks and come to us, sir.
Yeah, so we're actually picking up more
PET
patients
scan.
with sarcoid as we're going along. It was probably
PET scan.
undiagnosed earlier, especially you have a particular kind of a pattern on the echo, and then of course, and conduction abnormalities or arrhythmias. These are the patients I think you should screen for a sarcoid.